forces for the advancement of clinical research and the means to build the knowledge base of the profession. That has been a focus of the profession for many years. And AOTA continues to advocate for occupational therapy on Capitol Hill, and in 2017, AOTA will mark its 100th anniversary, and at this point represents more than 36,000 OTs, OT assistants, and students. It provides a broad array of services and benefits that are important to know about, including this pictorial on the history of occupational therapy. So let's get back to introduction. And I will just focus this and tell you that in addition to the individuals that we have talked about, there was an occupational nurse, Susan Tracy, who published studies in invalid occupations. She felt, and this was in 1910, she felt that it was very important for selected activities. So in other words, for the first time, people were assessing the patients and the needs that they had, and they selected specific activities for them to be involved in to address whatever limitations or disabilities they were seeing. She felt that occupations, patient occupations, should be a subspecialty of nursing, and felt that it needed to be part of the nursing curriculum. In New York, around the same time, Susan Cox Johnson was an arts and crafts teacher and wrote a textile book and was the director of occupational therapy for the New York State hospital system. It was her impetus. She sought to demonstrate that occupation could be morally uplifting and improve the mental and physical state of the patients and inmates. It could help improve their status, and they could contribute to their own support. So occupation was also seen as functional and important. And you can see this movement away from the idea that Philippe Pinel had in the 70s, that it was being involved in occupations or activities was used to divert their minds away from their disturbances and towards improving health. But we're now at the point where Susan Cox Johnson is suggesting that activities actually could be uplifting and improve the mental and physical state of the patients. Eleanor Clark Slagle from Illinois was known as the mother of OT. She was actually a social work student, and she developed the idea of habit training, that directed activity could restore health. And she organized the first school for OT practitioners, the Henry B. Flavel School of Occupations. And then she herself hosted the American OT Association in her home for many years and held offices, every office in the association. She is very beloved, and her, the AOTA has created a scholarship in her name and also a lecture in her name. So the individuals who are invited to lecture at the conference every year, the Eleanor Clark Slagle Lecture, is usually a real visionary individual who has important ideas for the profession, evidence-based, research-oriented, and is promoting occupational therapy. The other two individuals that are important for you to know about include William Rush Fenton, who was an MD, who was a psychiatrist at the Shepherd Asylum in Maryland. He was considered the father of occupational therapy. He was the president of the National Society for the Promotion of Occupational Therapy and its president. And he contributed a great deal because he created a journal, and he was the editor of the journal for 21 years. And the journal, in fact, is one of the mechanisms that helped promote the profession and get the information out. It was his feeling that work was better than idleness, and that he expected his patients to actively participate in the workshop. And there was a crafts regimen in a structured environment. He developed the principles of OT, that occupational therapy should be curative, interesting, purposeful, and it should be for something other than for attention and interest. So it was not just a diversional activity, to keep individuals occupied, that it should increase a patient's knowledge, preferably occur in a group, and that the occupational therapist needed to assess the patient and encourage the patient and stop before the patient was fatigued. He published in 1915 a manual for nurses called Occupational Therapy, a manual for nurses. In 1921, Adolf Meyer, a psychiatrist from Switzerland, immigrated to the U.S. He was a professor of psychiatry at Johns Hopkins University. His perspective, this is important for as we think about what is the philosophy of the profession, his perspective eventually formed the philosophical base of the profession, that purposeful activity and productive use of one's energy promotes health, that there is a psychobiological underlying basis for mental health and mental illness, that we need to take a holistic approach. We're considering mind, body, and spirit, that activity is a distinct human characteristic and a primary need of an individual in order to be healthy. He also felt that we need to balance the rhythms of day and night and balance the rhythms of work, play, rest, and sleep. Those were the early contributors to the field, the founders of the profession, and the individuals who began the association. In terms of societal developments that affected the field, World War I, which occurred from 1914 to 1918, meant that there was a large need for individuals to rehabilitate soldiers. And the idea was to rehabilitate them for military or civilian employment, because many of them were injured in a way that they could not return to their previous jobs. So there was a program that was directed by orthopedic professionals, including physical therapists, vocational evaluators, and OT practitioners, who were at that time called curative or bedside therapists. There were short-term, quick training programs that were set up for reconstruction aides that began in 1918 at the Walter Reed Hospital right at the end of the war. And reconstruction aides were sent overseas. There was a huge demand, and this demand led to a need for more training. The requirements for the reconstruction aides included they had to have a high school diploma, they had to have some instruction in arts and crafts, medical lectures, hospital etiquette, and practical experience in the hospital or clinic. The reconstruction aides did a fabulous job and were really in a difficult situation. There was minimal training, really. There was minimal equipment. And they were sent over and had to basically make do with what they had. There were many, many injured soldiers, as you can imagine, and limited budget and that sort of thing. So they were fighting an uphill battle. At the end of the war, schools for reconstruction aides closed, and however, the need for reconstruction aides was the entree for the field of occupational therapy into the treatment of individuals with disabilities. Prior to that, occupational therapy had been primarily focused on working with individuals with psychiatric illnesses. Societally, in World War II, 1939 to 1945, that was where the rehabilitation movement began, and especially when the occupational therapy services were recognized by the armed forces. So occupational therapists that previously had been civilian jobs became military jobs, and so were accepted, and the service of occupational therapy began to be very strong in the Army. In the mid-50s, the developments in drugs, especially neuroleptic drugs for psychiatric conditions, meant that individual psychosis could be controlled and their anxiety could be lowered. So therefore patients could be discharged into the community. There was a national deinstitutionalization plan that led to the development of community mental health programs. At that point, the deinstitutionalization plan, much like today, unfortunately means that many individuals who actually may need a fair level of structure and support are being put into community programs where there is less expensive support. And it unfortunately has displaced many individuals, and including leaving many individuals homeless with mental health issues who are now out in the community. There were a number of programs that were established for individuals with developmental disabilities, in those days termed retardation. There were also new vaccines that led to almost the elimination of polio and TB and changed the focus of long-term rehab. Pick up where we left off. The new vaccines were helpful, led to the near elimination of TB and poliomyelitis. Within OT itself, there was an increased interest in science, and the AOTA linked up with the AMA. In fact, the AMA was responsible for accrediting the schools, and eventually that link was broken. I'm not sure exactly when. However, part of what happened with that link was there was a much more increase in physical medicine and specialization in physical medicine. So it really led to more of a reductionist rather than a holistic attitude in the profession. Reductionist is, with specialization, you're really concentrating on an area of the body, a particular condition, and really kind of breaking down an individual to body parts and illnesses rather than a holistic person. Many advances in technology happened in the 60s, especially in regards to fabrication materials for splinting, which enabled us to do many new things for making prosthetics, for making seating systems, and it really altered the face of rehabilitation and what could occur in rehabilitation. There were also many legislative effects. You heard earlier about some of the laws that AOTA was involved in helping establish. In 1943, the Occupational Rehab Act was very important because it covered medical services for those injured by accident or illness while employed, and occupational therapy was included as a service that was required under this law. Medicare actually changed the face of healthcare entirely. Medicare is Public Law 8997. That's not something you'll ever be asked, but it was incorporated, it was put into law in 1965. It demanded coverage for inpatient and outpatient medical services for the disabled and those over 65. So this is, because occupational therapy was included as a primary service, it meant that the role of occupational therapy. Medicare changed a great deal of healthcare, and particularly for occupational therapy, as occupational therapy was an included service. In 1988, the Medicare law was changed once again such that OT practitioners in private practice, and not just those in inpatient and outpatient medical services, were able to apply for provider numbers, which means they were able to bill for their services even if they were in independent practice. That opened the door for occupational therapists to be involved with Medicare billing and therefore to increase their patient base. Some other important pieces of legislation occurred particularly for individuals with disabilities. These included the Rehabilitation Act of 1973, sometimes known as Section 504. In the Rehabilitation Act, employers and institutions of higher education that receive federal funds must accommodate the needs of employees and students with disabilities. It prohibits discrimination in employment or admissions on the basis of handicap. For that reason,